Well, welcome everybody. And first of all, I just want to thank all of you for taking all the time that you're taking to attend this virtual conference. It's been great seeing the turnout to the sessions. And I've been a longtime Ryan White provider for about 25 to 30 years. And it's great seeing everybody with so much interest and such a great turnout to the conference this year. What I'm going to try to do is I'm going to try and expand on some topics that I addressed in the session, in the main session today. And you know, this is all new to all of us, and how to do an effective Zoom workshop to me is somewhat of a mystery still. So it's very difficult with a whole lot of people in the room to get a lot of conversation going. So as a guide, I'm going to try and present a bunch of cases and have us try and get through a number of cases that are very relevant. And then, so Marty, the only thing is I can't get, there we go. Okay. So should I just be advancing on my keyboard, or do I need to be advancing at the bottom?
However works best for you.
Okay. Sounds good. So what I'm going to do, because I think it could be a free for all and very difficult, I'm going to try and go through a number of cases and basically let me just go ahead and jump right in. Let's tackle that. We'll have a number of Zoom pollings. And then, so this will give a chance to everybody interact. And I am going to also see here, okay. And can you still see everything? Okay, let me go ahead and get up. So Marty, the only thing is I can't see the chat room in this as well. Why am I not seeing the chat now?
I do not know the answer to that, but Kevin, who is our moderator, should be able to see that, and he can get questions or even ask people to respond to ask.
Great. Yeah, it was. So if I go to full screen, then to be able to share this, I'm not seeing it. I'm not seeing. Okay, wait a second. Now you drop that down. See if there's a way to do the chat.
Dr. Spach, do you have at the top of your screen a drop down that says View Options?
Yes.
And then there's a side-by-side mode, I think, is one of the options, and that should allow you to see the chat, I believe.
I don't. I just have. No, there is no view option at the top.
Okay.
This is not the usual. It looks different than, I don't know if I should share again and retry it.
We can see your slides, and you have clicked on the chat icon at the very bottom of your screen.
Yeah, I'm just not sure I lost it once you went live.
I see.
Okay, there we go. I found a pop-up window that I pulled over. Okay, great. We're good to go now. Thank you, everybody. Okay, so it really is important that I be able to see the chat, and I had to go to a pop-up window to get it. All right, let's jump in with opportunistic infections here. Okay, so first case is related to candidiasis, and this is a 31-year-old man who has HIV. He's been off antiretroviral therapy for about 6 months. This is going to be a polling question, so everybody get ready for it. He now presents to clinic with white patches on his oral mucosa, and he's diagnosed with oral candidiasis. And this is what it looks like. Okay, so pretty straightforward. Now, just as a warm-up case, what would everybody do here? Based on the OI guidelines, which one of the following would be preferred therapies? This is a polling question for everybody. It would be number 1, clotrimazole, 10 milligram troche, 5 times a day for 7 to 14 days. A nystatin suspension for 46 mils, 4 times a day for 7 to 10 days. Or fluconazole, 100 milligrams times 7 to 14 days, or fluconazole at a higher dose, 200 milligrams for 3 days. So what does everybody like here? Okay, a couple more seconds. Got good responses. Just a few more coming in. Okay, great. So nice job. I think this was a great warm-up case. The correct answer here is going to be fluconazole. So that's perfect. So the OI guidelines now have clear recommendations on this, and you can stop sharing the results here. That's great. So the correct answer, I think most people got it, more than 80% of people. And this is what the OI guidelines are now showing. The OI guidelines years ago, we used to have a lot of concern about using fluconazole because we had so many people on it over and over again. We had to be concerned about drug resistance. And they really shifted as we started to need to use it less to a standard recommendation of fluconazole, and all the topicals moving to sort of second line therapy at that point. So that's great. Everybody pretty much nailed that first case. So let's look at the second one, a little bit different scenario. So this is also going to be another polling case, 24-year-old woman with HIV, recently diagnosed with HIV. She was diagnosed several weeks ago, and she's seen now for screening and performed at a pregnancy visit. So she's estimated to be 10 weeks gestation. She has a CD4 count of 210, and she's receiving raltegravir plus TDF-FTC. So raltegravir, TDF-FTC, and she has new HIV diagnosis, and now she reports vaginal itching and burning, and pelvic examination shows vulvovaginal candidiasis. So the question now for her, and this is going to be a polling question, is how do we manage this vulvovaginal candidiasis in this woman with HIV? So based on the OI guidelines, what would you recommend here? Clotrimazole 2% cream for 3 days, a single dose of fluconazole, or fluconazole for 3 days? What do you like here? Okay, great. You can stop the polling. So actually, there's a pretty even split here, and this is a newer recommendation, and the correct answer is actually going to be number 1. So here's what we're now seeing as recommendations for candidiasis in pregnancy, and these are definitely newer recommendations. So the treatment of candidiasis in pregnancy, topical therapy is now preferred. For vulvovaginal candidiasis, topical therapy is considered essential. So this woman, the new guidelines just updated in May, they would say a woman who's pregnant, vulvovaginal candidiasis, absolutely give them topical therapy. And what they're saying now in the guidelines, avoid any dose of fluconazole in the first trimester. So the risk of using fluconazole during the first trimester is spontaneous abortion, even with the single 150 milligram dose, and cardiac septal closures, defects with higher exposures, like greater than 400 milligrams. So the main thing in a woman like this would be spontaneous abortion. So even single dose fluconazole is now out, and that's a newer recommendation. Okay, next scenario is MAC prophylaxis. Okay, so if you have any questions, go ahead and type them in. I'm not seeing anybody right now, but please chat in if anybody has any questions. Let me pause there for a second, see if any's got one. Okay, I will keep it moving along because we'll try and get through a number of issues here. So MAC prophylaxis. So what would you do here? Another audience response case. So polling question, 27-year-old woman, newly diagnosed with HIV, her CD4 count's very low at initial diagnosis, 34. She's got a viral load of 78,000. She's immediately started on BIC-TAF-FTC. So the question is, what is now recommended regarding MAC prophylaxis for her? Would you start daily azithromycin, start once weekly azithromycin, start daily azithromycin plus rifabutin, or do not start prophylaxis at all? Let's see what we got here. Couple more seconds. Okay, great. You can stop the polling. So we've got about 2/3 of the people selecting do not start prophylaxis, which is the correct answer. So once weekly azithromycin is clearly what we used to do, and these guideline recommendations changed about a year ago, going from sort of like you could consider giving prophylaxis to formally saying now it is not recommended. So current recommendations are as follows. For preventing first episode of disseminated MAC, primary prophylaxis is not recommended in adults who immediately initiate antiretroviral therapy. So this is the typical scenario like this. Someone newly diagnosed, low CD4 count, you're trying to minimize the number of medications that are going to go on, the number of drug interactions, the number of GI side effects. So I think this is really helpful now that we have this recommendation that you don't have to initiate MAC prophylaxis and start someone on this. Now, if for some reason a person was willing to take MAC prophylaxis, but they didn't want to take antiretroviral therapy, and their CD4 count was 20, sure, I would start them on MAC prophylaxis at that point. But this recommendation came from some data that clearly showed that really the MAC incidence now in the modern era of antiretroviral therapy is very, very low. So if you look at this study, which looked at sort of what's the risk of developing disseminated MAC if a person starts on combination antiretroviral therapy. So all the people in the study are the gray bar, and you can see overall the incidence of MAC was per 100 persons was very low to begin with. So in the modern era, we don't see a lot of disseminated MAC. Now, if you look at, if you starting antiretroviral therapy and you give prophylaxis versus not giving prophylaxis is the dark blue bar. The light blue bar is not giving MAC prophylaxis. So in that setting, you can see there's a little bit of a difference, but it wasn't statistically different, and the numbers are so low. Another part of this study showed that if you look at people and you look at after they've been on antiretroviral therapy for 2 weeks, most people who are into gray-space regimen, their viral load is less than 1,000 by 2 weeks. And another independent predictor of developing MAC was a viral load greater than 1,000. So with a low viral load, starting on antiretroviral therapy, it doesn't seem now that there's any reason to start people on MAC prophylaxis if you're going to start them on antiretroviral therapy. Okay, great. So again, anybody that has any questions, Marty, I just want to make sure that I would be seeing the questions. I'm not seeing any in the chat room now. If there are, if you want to redirect me. Okay, maybe I just need to scroll down. There we go. Okay.
There is a question.
Great, thank you. Okay, great, thank you for chiming that. So what about someone who's been undetectable for years, but now has a CD4 count less than 20 due to cancer treatment? Would you start azithromycin or not? My answer to that is I would not in that individual, but that is a really interesting question, and there is no data on that. What we would extrapolate from is again, the study that I was just mentioning, viral load was another independent predictor. And we know from the data with pneumocystis pneumonia and with toxo that viral load is a very strong predictor of people and developing an OI. So I think all of you are probably familiar with this now, or most of you have heard this, but if a person develops, gets on antiretroviral therapy and their CD4 count goes above 100 and they're suppressed for at least 3 months, there's now a good option that you can stop pneumocystis prophylaxis. So viral suppression there, even with a lower CD4 count, really translates into benefit. So I am extrapolating from that data, but that question is actually really, really a good one. So, and then, okay, great. So the other person says you should follow the cancer guidelines. So pneumocystis prophylaxis would be very different than an individual like that. I would clearly give pneumocystis prophylaxis, but we're talking about MAC prophylaxis. Keep the questions coming, that's great. Now I'm gonna shift gears to cryptococcal meningitis. And I wanna just emphasize that cryptococcal meningitis is a little bit different than some other scenarios that we look at. And so to hit a couple of key points related to cryptococcal meningitis. So 37-year-old homeless man is admitted to the hospital with fever, confusion, and headache. He's diagnosed with cryptococcal meningitis and HIV. Initial laboratories show an HIV viral load around 245,000, CD4 count of 68, and a drug resistance genotype is ordered. So sort of classic cryptococcal meningitis. Now, audience response or polling question for you. So he had a high opening pressure on the lumbar puncture. And just a teaching point for everyone, if you are clinically involved with the care of any person with HIV that you are suspecting cryptococcal meningitis, even if you're not going to do the workup, make sure and convey to the emergency room or urgent care who'd ever be doing this, that it's essential to get an opening pressure on anyone with suspected cryptococcal meningitis. Because if it's high, then you're going to need to do serial lumbar punctures. And that's exactly what happened with this man. He got serial lumbar punctures, and that's the plan. So in addition to managing the high pressure with serial lumbar punctures, what would you recommend essentially for the additional therapy? Would it be number 1, amphotericin plus dexamethasone? Number 2, liposomal amphotericin B plus dexamethasone? Number 3, liposomal amphotericin B plus 5-FC, or a full regimen of liposomal B, 5-flucytosine, and dexamethasone? What would you recommend? Okay, we've got a good smattering here. Keep them coming. Okay, great. We can stop the polling now. So this is interesting because in the main session, I discussed this idea of preemptive therapy with TB. And we know that, for example, with TB meningitis, we give steroids up front, but we do not give steroids up front for cryptococcal meningitis. So cryptococcal meningitis is a bit tricky from that standpoint. So now let's look at a couple. So the correct answer here, just to clarify, would have been number 3. So combination 2-drug antifungal therapy is recommended. Liposomal amphotericin B is much better tolerated than standard amphotericin B because standard amphotericin B has a lot of nephrotoxicity and hypokalemia and other problems. Liposomal amphotericin B, much less so. Addition of 5-flucytosine improves outcome, but dexamethasone is not recommended. Okay, so standard therapy now, induction therapy is going to be at these doses. So it's combination therapy, and amphotericin B is an alternative to the liposomal amphotericin B. So you'd only use amphotericin B, standard amphotericin B, for example, if cost or access to the drug was really your dominant factor. So there's a formal recommendation now in the guidelines that corticosteroids and mannitol have been shown to be ineffective in managing intracranial pressure. They're not recommended. So if you're managing someone with cryptococcal meningitis, the key is you manage the pressure with serial lumbar punctures and not with steroids and not with mannitol. So this is, different than what if you've not managed a lot of these patients before, and this is really a very different approach than, for example, with TB meningitis, where you give steroids up front and you don't really do serial lumbar punctures in the way we do with cryptococcal meningitis. Now, what about the issue of when to start antiretroviral therapy? So he started on amphotericin B and 5-flucytosine. He's getting serial lumbar punctures. And typically we try and get the pressure down to less than 20 every day or 200, depending on what units you're using. You take off usually 15, 20, 30 cc's, and that's enough to do it. So when should you start antiretroviral therapy? So this is another polling question. Would it be immediately in about 1 week, or would you defer for 2 to 4 weeks? What do you like here? See if we have can we get the polling question up for this one?
I'm afraid I don't have that question.
No worries at all. So this one, think about it for a second. 5-flucytosine, ampho on board. Would you defer? And the answer in this one is actually going to be number 3. You want to defer in this situation. So again, cryptococcal meningitis kind of behaves differently than other opportunistic infections where we like to get antiretroviral therapy on board right away. We do not want to do that with cryptococcal meningitis. So no steroids and no immediate therapy. So the scenario we're all concerned about with these major OIs is this idea that someone, as you're bringing down the viral load, is shown in the line with the squares going down, just following this curve down. With the drop in the viral load, the immune system starts to reconstitute, and it actually can be harmful. So for example, with a disorder like cryptococcal meningitis, where you have a closed space, if you get too robust of an inflammatory reaction with immune reconstitution, it actually can sort of set you back to where you were at the very beginning with these very high intracranial pressures, and individuals can do very poorly. I've actually seen this before. And for all of you that may follow these individuals, even if you're following them after they get discharged from the hospital, this immune reconstitution with cryptococcal meningitis can happen way out after people been on therapy for a long time. So it's not just in the first couple weeks. You can see this immune reconstitution down the road. So have your radar up for that and out for this in people with cryptococcal meningitis. So here's again how this is just a little bit different than other OIs that we manage. So cryptococcal meningitis has this 3-phase treatment. They have the induction phase, And then you really want to tap them after that, make sure they're clearing their infection and that they're doing okay. If all looks good, then you move to the consolidation phase. And then that's going to be usually at least 8 weeks. And then they need a maintenance phase that's going to be at least a year. So you don't get off light with cryptococcal meningitis. It's a very intensive course of therapy. There's no easy way to kind of get them off therapy in 6 weeks. It's a long course to manage them. Now, the good news is the maintenance therapy is oral fluconazole, so people can do really well for that. But notice down on the bottom bar here, you want to defer antiretroviral therapy during this induction period. You want to get the organism burden down extremely low before you risk jumping in and having an inflammatory reaction to these organisms. Most people would initiate therapy with cryptococcal meningitis with antiretroviral therapy sometime in this period, say 3-4 weeks after they've been on therapy, something like that. And then again, you're going to want to, obviously, once you get them on board, keep them on antiretroviral therapy. So cryptococcal meningitis, a little bit different. Again, no steroids, defer therapy. That's what's different about it. Any questions on that? Just, and if somebody wants to unmute and jump in, absolutely, please do that. Please do that. If anybody wants to take a second and unmute themselves and ask a question. They want to chat in the chat room too is great.
I have a question. For the
Great.
patients who have late ARS related to cryptococcal meningitis, is there data to support steroid management at that point?
This is a great question. We actually have just agonized over this in the clinic several times. So there's not data on this. What most people have done in this past is definitely go back to doing lumbar punctures to try and lower the pressure. Most people would not stop antiretroviral therapy unless it was absolutely life-threatening and they were neurologically declining. And most people that I have seen that are neurologic experts in this setting have not given steroids unless they felt like there was acute neurologic decline. So if it's headache and they just have high pressures, most people would not, but somebody who's got frank, neurologic onset, we've seen people just throw in dexamethasone high doses at that point. And I think that's reasonable because I think the pathogenesis is a little different than it is with early infection. But the bottom line answer to your question is there's no data, and I don't think we'll ever see a study done on this. We'll only hear, probably anecdotes about this. So hopefully that answers your question as best as we can. So I'm just seeing a question coming in related to my comments about the pneumocystis pneumonia prophylaxis. So the person is asking, so just to clarify, can PCP prophylaxis be stopped after CD4 count is greater than 100 for 3 months? So let me clarify. In a person who doesn't have cancer, not like that original question that came in, just standard person with HIV, you've got them on antiretroviral therapy. If their viral load is suppressed on antiretroviral therapy and their CD4 count is above 100 for at least 3 months and they have suppressed viral load, the answer now is yes. You can stop stop PCP prophylaxis. That is formally in the guidelines now. It's been there for about a year, and it's based on about 8 or 9 studies that showed those individuals when you stop PCP prophylaxis, as long as they're above 100 for 3 months and they're virologically suppressed, they do great. Now, a person with cancer who has and somebody nicely chimed in, follow cancer-specific guidelines. So if somebody had a CD4 count under 200 and they also had cancer, or they had another overarching issue that caused their CD4 count to be low, that would be different. I would continue PCP prophylaxis in that setting, if that makes sense. Okay, so the question now is, what if the MIC of fluconazole is way high, greater than 32? This is a complicated question. In this kind of case, you would not use fluconazole for maintenance therapy. You may be stuck with low-dose amphotericin. You would want to get susceptibilities to posaconazole and others. And anybody that had a situation like that, my recommendation absolutely would be to get an infectious disease consultation. Or for all of you, if you've never used the clinician consultation center at University of San Francisco, it's outstanding. And anybody it's free consultation, complicated patients like this, those are great that you can call in or email in and be able to get an answer to that. So cryptococcal antigen to guide therapy, to guide treatment. The answer to that is we use it initially, but and yes, it is used, but the gold standard in this situation, when you're deciding to, can you move to consolidation therapy, the gold standard is to actually do a lumbar puncture and confirm that they're culture negative at that point, because the antigen can remain positive for a long time. So we do follow titers in some people, but my recommendation is it's not reliable. And so if a person is trickling along with a persistent positive cryptococcal antigen, I don't think it means anything. I think you follow them clinically. Again, the decision to go to consolidation therapy should be based on culture. Now, antigen is extraordinarily useful for diagnosis. So the initial diagnosis, 95% of people or more who have cryptococcal meningitis also have a positive serum cryptococcal antigen. So a serum cryptococcal antigen is a great screening test in somebody with a headache and fever and a low CD4 count. But if you suspect cryptococcal meningitis, especially if you have a positive serum, you want to move on and do a cryptococcal and do a lumbar puncture and do a cryptococcal antigen on the lumbar puncture and the spinal fluid. So bottom line on that, cryptococcal antigen, much more useful for diagnosis, not very useful for monitoring on therapy, and culture is what you use to decide whether or not you can move to that consolidation phase where you don't have to have the high dose liposomal amphotericin B and 5-flucytosine. Okay, keep the questions going. Those are great. Okay, question now. Use of fluconazole in patients with positive CRAG, no symptoms, and CD4 count less than 100. So not a lot of data on this, but my recommendation is those people should get an evaluation. So if they are asymptomatic, a person who has a positive cryptococcal antigen, I would start by probably doing a chest x-ray and blood cultures. And then I would, if their CD4 counts less than 100, I would then, if those are negative, I would move on and do a lumbar puncture, because they could have low-grade early cryptococcal meningitis in that setting. If nothing turned up positive, then yes, I would use fluconazole in that situation. And that's one that I think, again, that's a really complicated scenario. That would be a great one to get input in from something like the clinician's consultation line. Okay, keep the questions coming. Those are great. So now take a minute and get a piece of paper and pencil. If all of you have access to that, I'm going to wait just a second, because I kind of have a lightning round here of test your clinical skills. So if you can grab a piece of paper and see if you can commit to writing down a diagnosis for these. These are not going to be polling questions, but they're going to be a series of clinical cases. So if you can, grab these, and we got 10 of these coming your way here pretty quickly with rapid fire. Okay, everybody's ready? Let's go to the first one. There's going to be 10 questions. See how you do. Okay, this person's referred by his dentist after the dentist astutely made a diagnosis of HIV based on this finding. CD4 count at this time is unknown. The virus that causes this disorder also causes multicentric Castleman's disease. What's the diagnosis? I'll wait about 20 seconds, give you a chance to write it down. Then you can keep your own running score at the end, see how you do. Okay, so the answer to this is going to be Kaposi sarcoma. So remember that Kaposi sarcoma is caused by human herpes virus type 8. We know that that's the same virus that causes Castleman's disease. So those of you that have ever seen a person with Castleman's disease, they can present with a multitude of variable manifestations, but most likely have really painful swelling and intermittent swelling of the lymph glands. But it's all the same virus, HHV8. And remember that Kaposi's can appear anywhere in the body, the mouth, the genital tract, the skin, multiple different places. So that's Kaposi sarcoma. Okay, what do you think here? We're looking at the roof of this man's mouth, and he's got his head tilted back, and we're looking at his upper palate here and his upper teeth. So CD4 counts 126. The mouth burns when eating spicy food or drinking orange juice. What do we think he has? Granted, it could be several different things, but this is actually an individual who has what we call erythematous candidiasis. The teaching point is, for those of you that may be newer in HIV, where you don't see as much of this as we used to see years ago, people with HIV can present with the classic pseudomembranous candidiasis. They also develop this variant called erythematous candidiasis, where they just present with a lot of burning, a lot of discomfort, taste isn't good. But when you look in their mouth, everything is more red than it normally looks. And that's the key to the diagnosis. So erythematous candidiasis is the diagnosis there. Okay, let's see what you think on this one. CD4 count very low, 42. Lesions on the face for a while, longer than a month, believe it. And they're gradually getting bigger. New diagnosis, not on antiretroviral therapy. The clue here, the pathogen that causes this problem actually activates the very drug that we're going to prescribe to treat this pathogen. Anybody want to shout this out or unmute and tell me if they know what this is? This is a hard one. Go for it.
Is it HSV?
Excellent. That's fabulous. That's exactly what this is. So just looking at this, and the question is, well, why is the clue the drug, actually the virus activates the drug? Well, here's the mechanism. So the drug Acyclovir was really tailor-made to be used with herpes viruses. And so this is actually what happens. So ACV here is Acyclovir. We're looking at a cell in the body that's infected. And for Acyclovir to get activated inside the cell, kind of like HIV drugs have to get activated inside the cell, they have to be phosphorylated. The activation of it is an enzyme called thymidine kinase that is produced by herpes virus. So the activation of the drug is done by the virus. If you think about it, the virus is actually killing itself here. It's a fascinating mechanism. Very efficient because the active form of the drug is in very low concentrations in most cells unless the cell is infected with herpes virus, and then there's abundant activation of the drug and you get a lot of acyclovir triphosphate. And the acyclovir triphosphate eventually comes back around and shuts down the DNA polymerase and viral replication. Just like antiretroviral drugs, they're called chain terminators and obligate chain terminators. They work very similar to drugs like AZT and tenofovir and lamivudine and so on. So this is, the clue to this was the actual drug is activated by the virus. So, you know, if you're the virus, your herpes, if you want to escape this, you stop making this thymidine kinase. And that's what acyclovir resistant herpes is all about. The virus stops making this enzyme and outsmarts us. But fascinating mechanism, one of the most brilliant drug sort of designs and deliveries. The same thing for treating zoster, herpes zoster, you know, with valacyclovir. It's all the same. Okay, that was great. Michelle, that was excellent on that. Okay, CD4 count of 56. These lesions on this man have been present for at least 3 months. It's a new diagnosis and actually was not diagnosed with HIV despite seeing multiple providers with this. So, you know, a good learning case as well too. So the histology, if you were to look at this under the microscope and under histology, shows Henderson-Patterson bodies. And the other clue is disseminated cryptococcal disease can sometimes be mistaken for this disorder. So write down what you think this is. And then if anybody wants to unmute and take a shot at it, no answer is a bad answer because these are tough.
Molluscum contagiosum.
Molluscum.
Excellent, fabulous. So this is molluscum, and this is really what we call more sort of the really severe cases of molluscum that you can see. And molluscum contagiosum in individuals with low CD4 count, especially if the lesions are small, can look just like disseminated cryptococcal meningitis. So this is a classic example. This man, after he was diagnosed and treated with antiretroviral therapy, all of these lesions on his face melted away, and he was extremely pleased with getting started on antiretroviral therapy because this was obviously very disfiguring and stigmatizing. And so it was great once he got the diagnosis of HIV and got started on antiretroviral therapy. So that's excellent. Okay, here's a hard one. So a lot of wrong answers here. It will not be a problem. So let's see if anybody gets this. A person is taking pneumocystis PJP treatment with trimethoprim plus dapsone for 3 weeks. He had a history of sulfa allergy. He was screened for G6PD and it was negative. Comes into the clinic looking cyanotic. The lips are dark. He's got a dark gray, blue skin. Never seen anything like this before. The blood gas is drawn because he looks cyanotic. And then you look at the tube of the blood gas and it looks kind of like chocolate brown, really dark. So the question is, take a second, see if you can write it down. 2 questions. What's the diagnosis? And if you know the diagnosis, does anyone know what the treatment would be for this? Okay, I'll give you a second. Okay, let's see if we have anybody on that wants to take a shot at this, and do not feel bad if you call out the wrong answer. Anybody want to take a shot? Oh, somebody said it. Who was it?
That was me. Hemoglobinemia, and you treat it with methylene blue.
Fabulous. That's exactly right. So emergency room clinicians know about this, but a lot of HIV primary care providers that haven't seen a lot of dapsone being used aren't familiar with this, but that's outstanding. That's exactly what this is. So if you've ever seen this before, the first time I saw it completely fooled me when I was a resident. I had no idea what it was. And a person, they have this really ashen gray, unusual look. It's not like anything I'd ever seen before. And the blood gas appearance was not like anything I'd ever seen before. And the idea here is that you're taking hemoglobin and converting it from the +2 form to the +3 form. So that's what can happen in some people, not many. It's not a G6PD problem. It's just genetically, some people are predisposed. So you're taking the iron 2+, converting it to the iron 3+. What happens then, it doesn't unload the oxygen to the cells. So the person actually may have normal hemoglobin, normal level of oxygen, but they just can't unload it on the tissues. So methylene blue shifts this back the other direction and shifts you from the +3 back to the +2. So that's fabulous diagnosis there. Okay, this one's a little bit easier. CD4 counts pretty high, suppressed viral load, urgent visit for a spider bite, febrile, white cell count elevated. The pathogen that causes this carries the mecA gene. So let everybody have a second, try and write down, see how you're doing. And who wants to call out what they think this is?
Hi, this is MRSA, skin infection.
So it's a skin infection. And I'm sorry, and you think what is the skin infection?
MRSA, methicillin resistant Staph aureus.
Absolutely, fantastic. So this is MRSA. And so one clinical pearl, if you ever have someone come into the clinic and they say, I have a spider bite, it should be MRSA or MRSA till proven otherwise. So that's fantastic. So MRSA can cause these inflammatory skin reactions. And if you look at this, I mean, if you just looked at it, you may think it was a spider bite. The CDC, actually, this was so common that the CDC developed a teaching poster for clinic that they put up on the wall for you to put up on your wall that said, if you think you have a spider bite, get yourself checked for MRSA. So that's how common this is that people think this. Now, what is the deal about the mecA gene? So just to remind everybody a little bit about MRSA, this is methicillin-resistant Staph aureus, and it's very important because skin infections are usually staph or strep, and if you're just treating regular garden variety strep that's MSSA, you can use, amoxicillin clavulanic acid or Keflex, cephalexin, and you don't need to, you're fine. But if it's MRSA, those antibiotics will not work. So just to go back to a little bit of basic microbiology, the idea here is this is a MRSA organism. The MRSA organism has to build and replenish its cell wall. There's a protein called the penicillin binding protein that is critical as the enzyme that cross-links the cell wall of these staphylococcal organisms. That's what penicillin binding protein is. These penicillin binding proteins are studied across the membrane of these gram-positive organisms like MRSA. And again, their function is not sitting there to bind penicillin. Their function, the penicillin binding protein, is to cross-link the cell wall. Well, what happens in the beta-lactam antibiotics that we use them, we tie up these penicillin binding proteins. You give ceftriaxone, cefazolin, cephalexin, any of these, they tie up this protein and it can't cross-link the cell wall. Okay, now what about MRSA? With MRSA, the mecA gene in the organism expresses a protein called penicillin binding protein 2A, which is a different penicillin binding protein, which clearly can still cross-link the cell wall, but the beta-lactams will not bind to it. So if you are using cephalexin, Keflex, antibiotics like that, you will not interrupt the cell wall synthesis. And that's why we use antibiotics with a different mechanism of action with MRSA, things like vancomycin, trimsulfa, and so on. So that's excellent. Again, if you see skin lesion looks like a spider bite, think MRSA. The treatment for this in the outpatient, what for MRSA would probably be trimsulfa. If you're not positive it's MRSA, make sure that you add in streptococcal coverage with something like amoxicillin or amoxicillin clavulanic acid. And let me underscore that again. Trimethoprim sulfa to treat MRSA is great, but it does not treat strep infections. So if you're not sure and you don't have a culture back and it may be strep or staph, make sure that if you're using trimsulfa that you have a good strep agent on board. And that's in the IDSA MRSA guidelines and recommendations. That's not just my opinion. That's a number of people's opinion. Okay, questions 8 and 9 now. Let's see how you do on these two. CD4 count less than 20. This person's in hospice care. The lesions developed over 10 to 14 days. You definitely would want to, the clue is here, you definitely want to put on a gown when you see this person. So, number one, what do you think the diagnosis is? Write it down. Number two, what do you got for the treatment? Take just a second and pause. Okay, I got somebody who's typed it in. Let's see if anybody wants to call it out loud. Actually, the person that typed it in, you definitely got it. So you've got the rights to shout out the answer here. Looks like Ray. Ray, if you've got your, you want to put your audio on now and tell everybody?
Yeah, sorry, it may not work.
Oh, no worries. So the correct answer here is scabies, and it's actually, we now like to use the term crusted scabies. Historically, it's really been referred to more as Norwegian scabies, but crusted scabies is now, the Norwegians felt that this was not something that should be sort of, it was stigmatizing them. So now the term crusted scabies is used. So crusted scabies, and notice these deep fissures here. And if you ever see somebody like this with advanced HIV, or you can see this in homeless people, you can see this in people with neurologic disorders, these plaque-like lesions are actually wall-to-wall cakings of scabies mites. So this is an incredible number of organisms in these individuals that have this. So it's a big problem. If you ever diagnose a case of this, realize that you have basically you have to get your employee health people involved, and this can cause a complete scabies outbreak in a nursing facility or in a hospice care center or even in the hospital setting. So numerous organisms. The correct answer for treatment is ivermectin. So normally we do things like one treatment of topical permethrin. That is not going to touch this. You're not even going to get any benefit from that at all. So you need to go to an oral agent like ivermectin. It's 2 doses of it. And for those of you that have ever seen this, the dermatologists that I work with like to also use something called lachydrin, which will soften up all these plaque lesions as well too. And it just helps them in sort of the resolution. So excellent. This is crusted scabies. Treatment is ivermectin. And again, you have a big issue in terms of your facility that you're in and people getting infected. Okay, last one. This is kind of an easy one. CD4 count of 68. Asymptomatic lesions on the sides of the tongue that you can see here. You could find EBV in these lesions. So again, take a while.
Hairy leukoplakia.
Absolutely. Excellent. Oh, hey, Michael. So yeah, so it's hairy leukoplakia, and that's exactly right. So this is oral hairy leukoplakia, and we think that the vast majority of these are triggered by and caused by Epstein-Barr virus. It really doesn't cause any problems in 99% of the people that have it with HIV. And it's just a marker of some immunological suppression. And it's definitely something that should raise your attention if you're seeing somebody in a clinic and they're not known to have HIV and they happen to open their mouth and you see lesions like this, you should definitely screen them for HIV. And then the last point is these usually melt away when you put people on antiretroviral therapy. So fabulous work there from the crew and everybody here. I'm going to keep it going here on to the next section. Any questions about any of these cases? Anybody wants to chime in? Okay, perfect. Okay, now there's been a lot going on with hepatitis A. And any of you that work in centers where you have maybe more urban areas and have more homeless individuals, and they're probably with everything going on with COVID and the economic, we're going to see more homelessness and we're probably going to see more hepatitis A, unfortunately. So there's been huge upsurge of hepatitis A in the US. So that's why I'm taking some time and some brand new recommendations that came out a couple weeks ago. So this document, if you've not seen it, it's wonderful. It came out about a month ago in the MMWR, and it's a really nice official recommendation. I want to call out to everyone as well to one other document that just came out last week. For those of you that have always wondered, like, well, we've got these great HIV post-exposure prophylaxis recommendations for healthcare workers, but we don't have them for hepatitis C. Well, about a week ago, the CDC came out with really nice post-exposure protocols and recommendations for people, for healthcare workers following a hepatitis C exposure. So for those of you that may be involved in any occupational health at all, be aware of that. But you can see from this graphic here that the number of cases of hepatitis A have really gone up a lot in the past several years. I'm sorry, yeah, and they're, even this year, the number of cases is up even higher. So a lot of hepatitis A, a lot of outbreak. Okay, these are gonna be kind of rapid fire polling questions. So they're gonna be yes, no. So let's see how you do testing yourself on the most current hepatitis A recommendations. And these are all specifically now to people with HIV. First question, rapid fire. Should all adults with HIV who are not immunized to hepatitis A receive the hepatitis A vaccine? Yes or no? Awesome. Okay, we got this one nailed. I think we've got a good consensus on this. This is the warm-up question. So indeed, one is the correct answer. Everyone should be immunized. Okay. Question number 2. Let me advance it. Okay. No, I'm sorry. So this is the reference again for this MMWR, and for all people with HIV 1 year of age or older. So for those of you that do pediatrics, this recommendation now has been moved down to anybody with 1 year. Anybody with HIV 1 year, age 1 year older should get hepatitis A vaccine. Okay, should you perform post-vaccination serologic testing in persons with HIV who received the hepatitis A vaccine? Yes or no? I love it. We're looking at 50-50, maybe 60-40. Okay, so close the polling there. So we're almost 60-40. The correct answer based on these new guidance is yes. So I would say that this is a change from what we've routinely seen a lot of people do, and in some clinics. And so the CDC has recommended this. In the past, sort of the recommendation was, well, the vaccine take rates are generally really good. But I think the setting has changed, and that hepatitis incidence out in the community is so much higher, the stakes are higher, and we know that people with HIV, have overall a higher risk and have a higher risk of complications. So these new recommendations for people with HIV are to do post-serologic testing. So again, to remind everybody, now the other thing you may wonder about is when to do this. And I can give you my own opinion about this. So ACIP recommends at least 1 month after this, but there is a lot of data in people with HIV that there's more delay in seroconversion with people with HIV. So my own practice, what I do is I don't recommend getting them 1 month after the vaccine. You can, that's fine, there's nothing wrong with that. But I usually wait 3 to 4 months because I think, again, this issue that some people have a delayed serologic conversion, and if they convert at 6 months, that's totally fine. So the second question that people wonder is, what titer should you be using now? Well, these have been all over the map in the past for hepatitis A, anywhere from 10 to 33 to we have no idea. And in these new guidance, they recommend a titer of 10 milli-international units per milliliter or greater is what you use as your cutoff. And that's the same recommendation now that we have for hepatitis B for just standard post-serologic testing, a cutoff of 10 or greater. Okay, so the PrEP guidelines recommend HBV screening, but not hepatitis A. Should that be changed? That's an interesting question. I actually don't know if that policy is going to be changed. I could find out the answer to that because it probably got addressed in this guidance. The guidance had clear-cut recommendations for people with HIV, people who inject drugs. I do not remember off the top of my head for MSM, but maybe right at towards the end of this, I'll try and grab my my hepatitis document and look at it real quick and see. So that's if anybody on the call actually knows from this, we do screen among PrEP patients, but we do not check for seroconversion. Yeah, so that's interesting. Right, and that would be another recommendation that would be different than people with HIV. So great question. I don't actually know for sure if there'll be formal policy changes on those since this guidance just came out very recently. Okay. Should you defer giving the hepatitis A vaccine if the CD4 count is less than 200? Yes or no? Again, I like it. We got a little bit of a 60-40 shot here, 50-50. Okay, that's good. You can close the polling. Thank you. All right, so yeah, a little bit of a 60-40 here. So here's what the new guidance says. The guidance says, don't delay. But those of you that answered yes, delay, there's a good rationale behind why you said that, because it is clear that people do not get as good a response if their CD4 count is low. But the newest guidance, it's a little bit like the conjugate pneumococcal vaccine that, you know, even though they're a little bit lower, the risk of the disease is significant. So the ACIP recommends hepatitis A vaccine should not be delayed if the CD4 count based to wait till you get above any kind of certain threshold. So, but again, for everybody's standpoint, the CD4 count that's lower, you're going to have a higher non-response rate, which brings you back to it's super important in people with CD4 count under 200 that you're doing that post-vaccine serologic testing. Because those people, if they don't respond, yeah, then you're going to want to wait till their CD4 count comes up above 200 and then re-immunize them. Now, personally, for me, a person asked us about, you know, with conjugate pneumococcal vaccine or this, the recommendations basically say don't delay. But in the clinic, I can tell you what I do. If somebody's a new HIV diagnosis, new to our clinic, I actually wait till they're on antiretroviral therapy, and at their 1 month visit, I give them their conjugate pneumococcal vaccine. If you give it that first day, that's totally fine. That's right in line with what the recommendations say. I think waiting a couple of weeks till they're on antiretroviral therapy is fine. I personally would probably do the same thing here. I think waiting a couple of weeks, there's not a lot of downside. If follow-up is an issue and you're not sure about that, I would definitely go ahead and give the hepatitis A vaccine and the pneumococcal conjugate vaccine if follow-up is any possible issue at all. But again, the key point is you don't want to wait a long time and wait for their CD4 count to go above 200. You want to go ahead and give it. Okay, what about this? Should you give hepatitis A vaccine to a pregnant woman with HIV who's not immune to hepatitis A vaccine? So they need a hepatitis A vaccine, but should you defer this till after they're done with their pregnancy? Okay, got another good split here. So the reason I presented these hepatitis recommendations is exactly because of this. Hopefully there's some learning points for people. So the answer is, should you give the hepatitis A vaccine? The new recommendation is yes, give it. So you can stop the polling. So ACIP now says on this, yes, go ahead and give it. It recommends to non-immune pregnant persons with HIV and even without HIV with risk of having, I'm sorry, shouldn't say that without HIV. Pregnant persons, you give this to if they have a risk of a severe outcome. So that would include people with chronic liver disease and persons with HIV. So let me clarify again. Routinely, that you would usually defer this, but a pregnant person who has a risk of severe outcome, and that's going to be people where HIV are going to fall into this category, it is recommended to give that. So we don't defer therapy. We give it to pregnant women. And then the last polling question on hepatitis A is, how do you manage an exposure? So if you have one of your patients with HIV and they have a clear-cut hepatitis A exposure, a sexual exposure, a household, a food exposure, and it occurred within the prior 2 weeks, your patient is non-immune. So what would you do in terms of prophylaxis? Would you give them hepatitis A vaccine, immune globulin, and that should be a capital G there, IG, or hepatitis A vaccine plus, not IgG, that should just be IG, immune globulin. Sorry, I didn't pick that up when I proofed the slide. So hepatitis A, immune globulin, or vaccine and immune globulin. Okay, great. People did great on this one. You give them both. You give immune globulin. So one of the things to mention is that clearly everybody should get the vaccine. This can be the first dose of their series. Immune globulin for hepatitis A exposure is not as good as it used to be. So I think for everybody out there that may be dealing with this, for anybody coming in your clinic, even who doesn't have HIV, the reason hepatitis A immune globulin is not as good is it's a pooled immune globulin, and there's less hepatitis A seroprevalence in the population now than there was 15 to 20 years ago. The overall seroprevalence is less. So the immune globulin, which is pooled from the population, is you're just less likely to see high levels of antibody titers. So bottom line is that's why you would not just give the immune globulin alone. You'd want to give both. Okay, so that's all I had in terms of, so please chime in any additional questions. And then if people do not mount a response to the first hepatitis A vaccine, should we revaccinate? The answer to that is yes. Especially, it's important that if their CD4 count was low or they were not on antiretroviral therapy with one of the doses, definitely get them above that threshold for the revaccination. There is no sort of common recommendation to give double dose like we might do with hepatitis with hepatitis B. But yes, I would re-immunize that person. If they do not respond, then they need to be on the second time around. Then the recommendation is you counsel them. They are at risk if they ever have an exposure. That's an individual that you're going to be relying on immune globulin if they get a subsequent exposure. So that person needs to be counseled. If they don't respond, they need to come in if they have an exposure, and then you can give them immune globulin. So anybody want to chime in with any live questions or text questions? So are there any contraindications for administering the meningococcal vaccine and pneumococcal 13 together? I actually don't know that off the top of my head. If anybody on this knows off the top of their head, so that is a really good question, and I'm trying to think of it. It seems like we routinely do it in our clinic. I've never thought that there was a contraindication, but if somebody's aware of one, please let us know. If anybody knows, please chime in. Okay.
What are the current recommendations for HPV vaccine?
Okay, great question. So HPV vaccine. So the recommendations for people with HIV are different than people without HIV. In the general population now, and I'm assuming, Michael, you're more interested in sort of people above age 27, right? That's
yes,
what you're
above
getting
27,
at.
yes.
So below 27, the key recommendation is you never do the 2-dose series for people with HIV. You always give them the 3-dose series. Healthy kids that you're immunizing, you use the 2-dose series. HIV, always got to be 3 doses. Above 27, in the general population now, the recommendation between age 27 and 45 is to have one of those engaged shared decision-making. So a lot of people are doing it now in the general population. The HIV-OI guidelines recommend against that. It is not recommended for people with HIV. That is, it's not that they've ignored these other data. There are data in people with HIV that it just did not perform well in people with HIV in that age range, 27 to 45. So there's actually, it's not because there's no data, it's because there's data that suggested it did not work well. Now, was the issue that in persons with HIV, they had such a high seroprevalence by age 27 that you just didn't get much additional benefit? That may be possible, but the bottom line is for people with HIV, that is not a recommendation, and it's in the OI guidelines.
How about if you had a history of HPV and less than 27?
So history of HPV and less than 27, definitely give HPV vaccine. So, and now the only HPV vaccine available in the country is the Gardasil 9, which has 9 serotypes. And the recommendation is, because that has now multiple strains in it, not just 2 strains, but multiple additional strains that are cancer protective strains. People who have HPV, even if they've had HPV-related cancer, we still give them this vaccine because it may protect against other strains. So that's a pretty clear recommendation. History, sexual activity, sexual history, number of partners, previous HPV, warts, none of that matters. If they're under age 27, you can definitely give them the 3-dose vaccine series. But interestingly, in HIV, until there's new data, we're not recommending. Now, some of you may be aware that they are looking at the HPV vaccine as therapeutic or as an immunological booster in people with low-grade for example, anal cell pre-malignant lesions, and there's the Anchor study that's looking at this. But for routine clinical practice above age 27 now, not recommending.
Thank you.
Okay, so I think we're at our time. Again, I really appreciate all that you're doing out there in the trenches, taking care of people with HIV. Thank you for joining this session. Again, this is a little bit of an experience with trying to do sort of the Zoom, the Zoom breakout sessions, but hopefully you got something out of this. So enjoy the rest of the conference. Thank you very much.